Good afternoon, everyone. Can everyone hear me okay? All right, cool. Raise your hand or yell or something if I fade out, okay? I seem to have gotten the coveted after lunch speaking spot, so I'm going to try to keep you all awake, but, I might not be that good, so we'll see. I'm Morgan Fader. I'm a psychiatrist. I work with the HD Center of Excellence in Pittsburgh at UPMC. And I'm going to be talking about navigating inpatient psychiatric admission. This is the HDSA conference. That's why we have this slide. I have no conflicts of interest. Okay, so as you all already know, Huntington's is complicated. It's really complicated. There's an interaction between behavior, the movement disorder, and the cognitive problems that come with HD. And they all add up to make this a really difficult illness to live with and to care for people that are living with. So I'm going to be focusing on basically some of the things that we can do for the behavioral parts of the illness, but just keeping in mind that the movement and the thinking parts are all going to play into all of this throughout. And then it's also worth keeping in mind that Huntington's, as you all already know, will strike different people in different ways and at different times. So some people will get the movement disorder first, and then it's a little bit more clear what's going on. Some people, if they have behavioral problems first, it may be much less clear, particularly if there's not a clear history of Huntington's in the family. So that's another issue that we deal with. And, it's way too hot in this room, so. This was not initially part of the talk, but enjoy. Okay. And also, I should say right up at the beginning, I'm going to leave lots of time at the end for questions, so no worries. I'm happy to answer whatever questions you've got towards the end of it. So I'm going to start actually with a brief history of psychiatric hospitalization in the U.S., mostly because the way that psychiatric hospitalization happens and is managed now is very much related to what the history of psychiatric hospitalization has been throughout the history of our country. A lot of the issues that we have in getting people the care that they need sort of tie into how the system was built, and it helps us to know a little bit about how it was built to be able to say how to manage it now and how to navigate the system now. So forgive me for a little history lesson at the beginning here. One of the major issues in terms of psychiatric treatment is that psychiatric illness, including psychiatric consequences of medical illness, so the psychiatric complications of Huntington's disease, this is all unique in that there's no other medical problem really where people lose their insight and judgment. So if I have chest pain and I go see my doctor or I go to the emergency room, it can reasonably well be expected that I'm going to say, yes, please give me whatever medications I need because I'm having a heart attack. Okay. If I start to think that my neighbor across the street from me is out to get me and videotaping me and I may be in grave danger because of that, it's not quite so clear that I'm going to be happy to take a medication when I suddenly started thinking this, even though it's clear that I would need that. And so people who need help may not realize that they need it, and even if they realize that maybe something is going wrong and they need something, they may not accept help. And so involuntary commitment or involuntary psychiatric treatment allows another person to get help for the person who needs it and doesn't realize it. This, however, leads to a tension between what we call the right to treatment, so basically anybody's right to be well and right to have medical care to help them with the illness that they have, and that person's autonomy if they don't believe that they need treatment. So the history of civil commitment is kind of long and varied, but it's always been regulated by the states since we have a federal system, and every state has had different laws. However, the legal theory behind the laws governing civil commitment are based on one of two principles or a combination of two principles. One of them is parens patriae, which is Latin basically for the state acting as parent, the duty of the state to take care of the citizens of the state. And this is based on the ethical principle of beneficence, which is another kind of big word that we don't use very often. But basically, it's the state has a responsibility to take care of its citizens, and one of the ways that it can do that is to compel people to get treatment when they need it. This is in contrast to the doctrine of police power, which sounds a little bit more threatening, which is based actually on limiting danger to society from people's illness. So it's the idea that the state can compel somebody to get treatment because other people might be in danger if that person is ill. And to be fair, the idea that somebody might harm themselves, the state has a compelling interest not to have its citizens harming themselves, because you can't really be a productive member of society if you're not there. And so that also comes under police power, protecting the interests of society as a whole by protecting the members of it. So until the mid-20th century, most state statutes were based on a right to treatment model. However, there was a growing trend towards more regulations safeguarding patients' rights, because right to treatment is a little bit hard to enforce, a little bit hard to define. Who makes the decision that somebody needs treatment? How long do they need treatment? Where does that end? It ends up infringing on somebody's rights, because let's say my mother thinks that when I talk back to her when I was 16, that was a psychiatric illness, and she thinks that I need to be in the medical hospital or the psychiatric hospital because I was a bad kid. I don't know, where does that end? But at any rate, institutionalization was very, very common up till the 1950s, basically. When somebody had a psychiatric diagnosis, they were thought not to have the right to make decisions for themselves, basically about anything. So once somebody was labeled as having, say, major depression, it was possible then for a family member or a physician to say, because you have this diagnosis, you belong in the hospital. Whereas now we tend to think about things as you are thinking about hurting yourself and maybe have taken some steps to do that, then you belong in the hospital, not based on a diagnosis where somebody could actually be perfectly well, and yet somebody else could then say, but you need to be in the hospital because once you got that diagnosis, you can't make your decisions anymore. And so that would also be true of something like Huntington's disease that has behavioral manifestations. And, that's really problematic. So when family members could decide to hospitalize somebody based on a diagnosis, there were always competing interests there. Not always everybody had the patient's interests at heart. And so we ended up with a peak of more than 500,000 people admitted to psychiatric hospitals in 1953. Okay. So, and then the tide started to turn, and there were a couple of different things that led to this. In 1950, the first antipsychotic was marketed, called chlorpromazine or thorazine, and it helped people basically with things like hallucinations and delusions, and it led to the hope that a lot of people who had been institutionalized long-term would be able to live productively and with a better quality of life in the community. At the same time, or almost the same time, there was the civil rights movement, which led us as a society to think about people's individual rights somewhat differently than we had before, putting more emphasis on people's rights to make their own decisions, and more liberty for more kinds of people who hadn't necessarily been thought to deserve the same liberties as other people. So legislatures at the same time were also looking to cut budgets because a lot of state hospitals are expensive. And the closure of the majority of state hospitals basically saw the end of long-term hospital institutionalization in this country, and most of them were closed by the 80s and late 90s. So at the same time, because of all of this, I see my colleague is laughing because this is a picture of our hospital in Pittsburgh. The other two were state hospitals in Pennsylvania that are no longer open, actually. Now the state moves to make commitment harder. We're going to have fewer people in the hospitals, and we're going to make it harder to compel people for treatment. And so there are basically, in Pennsylvania, these are the criteria. It varies state by state, but it's all going to be along similar lines. In order to commit somebody against their will for treatment, there needs to be an imminent danger to somebody, either the patient or somebody else, or an extreme inability to care for themselves in the community. Basically, something where you would expect that they would have an acute threat to their life or serious medical outcome within about a month, about 30 days, if not treated. So this is generally really a positive shift. We're getting people out of institutions, back into the community, back with their families, hopefully getting treatment outside of the hospital. But as with all good things, or as with all things, there are generally negative unintended consequences that go along with that. So until the 1950s, until the deinstitutionalization started, what happened was that often the first interaction of somebody with the psychiatric system, the first way to get them into care was inpatient hospitalization. So when we take that option off the table for the majority of people, we need to have another way to get them into care. And so sometimes that doesn't happen. We're getting better at that. With some of the mental health parity laws, that has gotten better as well in terms of people being able to access treatment. But that's still one of our challenges. Often family members need to watch somebody get very progressively ill before they're able to get them help if they don't have insight into what's going on. And that can lead to illness being harder to treat and a lot of distress on the part of a lot of people, both patients and families. And then there's been a huge increase in psychiatrically ill people in jails and prisons. On any given day, it sort of goes back and forth as to which the largest psychiatric hospital is in the country. It's either the Cook County Jail, so right here actually, or the Los Angeles County Jail. Far and away, something like 600 beds close to in each of those, while this lovely building you see on my slide is about a 300-bed institution, and that's considered a large psychiatric hospital. So there's also been there's been a shift to homelessness for a lot of psychiatrically ill people since deinstitutionalization. It's estimated that about 25% of the homeless population has severe mental illness versus 6% of the general population. Okay, history lesson over, but at least you can appreciate some of the challenges we face when we're dealing with getting people into treatment, getting people care, and some of the barriers and maybe some of the opportunities we have in terms of getting people care. So as I went over there, psychiatric hospitalization is really the last option. It's used to preserve safety. It's not used at this point to get people into care particularly. It's there for when people need something and nothing else will do. Admission can be voluntary or involuntary at this point. Up until around the 1950s, when it was considered that anyone with a psychiatric diagnosis didn't have the capacity to consent to a hospitalization, there was no such thing as being able to check yourself in for treatment. Somebody else had to do it. And in some states, the theory is still that all admissions are involuntary to start with. I think California is actually that way. In practice, it doesn't really work that way, though. And then still, as I'm pointing out, actually, laws governing admission do vary by state. So usually psychiatric admissions these days are short stays when somebody's at risk of harming themselves or somebody else or can't care for themselves in the setting where they are. Sometimes we end up having longer admissions because it's hard to stabilize somebody, hard to get their symptoms under control, or because we don't have any safe options in terms of where they're going to live after the hospitalization. But the rule is generally about 7 to 10 days is how long a psychiatric admission lasts these days. Okay, so now sort of to bring this really into the nitty-gritty details, if you need a psychiatric hospitalization or somebody you love needs a psychiatric hospitalization, I think it takes a lot of the anxiety out of it if you know what you're looking at, if you know what to expect from the process. So I'm kind of going to walk through the nitty-gritty details of this. Right from getting into the hospital to the kind of treatment you might get. And Dr. Valby, who's speaking after me, also will speak about sort of more specific treatments, I think. This is more about how how all the care is delivered and what things you should know about and what things you should know to ask about as well. So, what can you expect in terms of getting to the hospital? There are a variety of ways that you can end up being admitted to a psychiatric hospital. I work on the inpatient medical units at our hospital in Pittsburgh, and so a lot of people that I will admit psychiatrically, actually I see in a general medical unit first. There may be an accident, there may be a suicide attempt necessitating treatment, there may be some other medical issue going on. Maybe somebody's been having trouble feeding themselves adequately, and so they need stabilization in terms of their nutrition before a psychiatric hospitalization. So that's one of the ways that you can get in. You'll be seen both by your medical team and then by a psychiatrist who will arrange for you to go to a psychiatric hospital after that admission, after medical stabilization. If you have outpatient psychiatric care to start with, then your outpatient psychiatrist may be able to arrange a direct admission where you don't have to go through an emergency room. It's arranged beforehand that you'll be able to be admitted to the psychiatric hospital. It takes one of the steps out of that. It's one of the reasons that it's a small reason, but it is one reason that it's good to have outpatient care before you need inpatient care, as it can make that transition easier if you need it. There are emergency rooms all over. There are medical emergency rooms where there are psychiatrists who see patients and do safety assessments. And then there are also, in some places, dedicated psychiatric emergency rooms where evaluations happen. Either one of those is an option for arranging for admission if that's what's necessary, or for arranging for a different outpatient care if that's also what's deemed to be necessary. Most places have community crisis teams that's usually organized by county. In Allegheny County, where I practice, there's a crisis team that will man a hotline, also send somebody to your home, and do a very quick safety assessment, try to give families and patients resources to increase their safety in the community, and also can transport them to an emergency room if that's what's necessary for a full psychiatric evaluation. And then sort of the most unfortunate way that people come to our attention is through the police. You see, I've got the card that every person with Huntington's should carry. I have Huntington's disease and my behavior might look strange to you, but I'm ill, please don't arrest me. Even people who have these cards, sometimes it seems that the police don't care to read them, but everybody should carry one of these. That said, the police sometimes will either arrest somebody with Huntington's or bring them to an emergency room. Most of the time, that's not because that person needs medical care or psychiatric care. Most of the time, that's just because they have Huntington's. Sometimes, though, we see people in the emergency room and they do actually need to be admitted because the police brought them there. Usually we're happy to send people home and try to educate the police at the same time. So once you've gotten yourself into the hospital, and all of this, actually, I should mention, you can either be admitted on a voluntary basis or an involuntary basis, sort of depending on the state you're in. One, you would sign a piece of paper saying you want this care. The other, somebody else would say, it would give a justification for that admission. And usually there's some oversight on the part of the legal system in the county in which it's happening. Different states have different regulations regarding that. So that I don't want to speak specifically to it, but there is judicial oversight of the process at some point in that process. Once you're in the hospital, there are going to be limitations in what you can have there. A psychiatric setting is pretty different from a medical setting. There's a much greater risk if people have belongings on them that are unsafe. One of the big ones that people get very, very upset about, and I would too, so not knocking anyone, is you can't have your phone. Anything with a camera on it or that could have a camera on it. It's a violation of the privacy rights of the other patients. And also, quite honestly, if what you're there for is getting treatment and paying attention to the things in your life that need to be changed, maybe Facebook isn't the place you should be. Not that it's not a temptation. Other things, sharp objects, belts, shoelaces, anything anyone could use to harm themselves or harm somebody else. what I say to people when I admit them is, we'll take these things from you, we'll store them, and we'll give them back when you leave. Not into taking stuff away from people, it's just not safe in the hospital. And also visitation, people can't come just anytime, usually during times when people are getting treatment, getting kinds of therapy, often during meal times, and then at hours when people, we hope, are resting, there won't be visitors allowed. So, who will your treatment team be? There are a lot of people on a treatment team. I feel lucky to practice in our Center of Excellence in Pittsburgh, because we have everybody in the same room in our outpatient Huntington's clinic. We've got, neurology, psychiatry, I'm going to forget somebody I know, speech therapy, occupational therapy, physical therapy, social work, nutrition, genetics, thank you. Did I get everyone? Oh, all right. And it's kind of similar in terms of a treatment team in the inpatient psychiatric setting. You've got a psychiatrist. If you're in an academic center, you may be lucky enough to have more than one. There will be a general medicine, an internal medicine or family medicine physician, a psychologist, social workers, nurses, milieu therapists, who I'll talk about in a sec, because I'm sure that's an odd term, and then a lot of people who can be called in as needed, all different kinds of physical, occupational, speech therapy, nutrition, neurology, anybody who doesn't usually, actually a lot of the therapists still work in the hospital, but neurology would come over from another building, that sort of thing. And so who are all these people? The psychiatrist, usually somebody with a medical doctorate or an osteopathic physician. I like to think of us as the team leader. Somebody else might not, but yeah, that's my bias, I guess. So we specialize in behavioral health. We specialize in all sorts of ways that things go wrong in the brain that the neurologists don't specialize in. And there's a lot of overlap between those two things, as in Huntington's, for example. We will be the ones recommending medications for behavioral health issues. We'll recommend psychotherapies. We'll recommend involvement of other specialties. The family physician or internal medicine specialist will usually supervise physician assistants or nurse practitioners and care for any physical health needs that somebody might have when they're in the hospital. So, diabetes is very common, hypertension is very common. They'll care for those conditions while somebody is hospitalized. A psychologist is somebody who works really closely with the psychiatrist, who will design the psychotherapeutic interventions. They'll probably have designed whatever programming there is on the unit in terms of group therapy. For somebody who needs a specific behavior plan, an example would be somebody whose cognitive abilities might have deteriorated quite a bit, who needs a specific schedule, like you must get out of bed and go and eat breakfast at this time in order to be able to get into a routine. People who tend to be somewhat impulsive might also benefit from a behavior plan, and the psychologist will devise those things and give recommendations about how to manage certain kinds of behaviors when somebody goes home. Social workers are usually master's level education. They coordinate discharge planning. They'll make sure that you have outpatient appointments with all the people that you need outpatient appointments with, outpatient psychiatrist, neurologist, whatever other medical specialties, and identify community resources. And this is really kind of huge in that they have the knowledge to find out what kind of programming there is in your area, what kind of sometimes it's activities, sometimes it's day programming, sometimes it could be any number of things, and can also coordinate with the Huntington's Disease Society in your area and get an idea of what you can do once you get out of the hospital, what other kinds of community supports are going to be out there for you. There are nurses who are always on the unit. They provide 24-hour care and support. They really go above and beyond. The nurses in a psychiatric hospital are trained in behavioral health nursing, so not only do they do things like give medications, watch for side effects, take vital signs, watch over a patient's physical health, but they also know what to do when somebody's having an emotional crisis, and they can intervene on those levels as well, whereas a nurse in the medical hospital might not be trained to do that. I can't even say it, milieu therapists. These are generally bachelor's or master's level trained people who are out with the patients basically 24/7. They're the person that somebody can go to at any time of day when they're having something that they need to talk about, or they're having some kind of crisis. And they're always there, and they're always able to intervene in a way that's supportive to the patient. They also monitor people's safety, so everybody gets checked in with on a certain schedule, be it every 15 minutes or 30 minutes or 5 minutes, depending on the patient. And then other people are involved as needed. And I think I described most of those people before. So again, what more can you expect? But wait, there's more. So you should have daily meetings with a psychiatrist. You should have daily group therapy. There should always be somebody available to talk to in real time, 24/7, no matter when it comes up. There should be somebody there. There should be regular communication with family and caregivers. Family needs to be kept in the loop to basically give the treatment team information that they need, and also get the information that the family is going to need for when the patient goes home. Family is going to know the people that we're treating a whole lot better than we do, and input from family is almost as important as input from the patient. Not quite, but. And then you should expect involvement of specialty care when appropriate. Just about any kind of specialty care, as long as it's not severe medical illness, can be arranged for while in the psychiatric hospital. Okay, so what else do we have? You can expect to be linked to resources, outpatient mental health services, outpatient medical services, and then appropriate supportive living. You can have medical professionals come to your home, things like home PT, home OT, home nursing, and then it may be that assisted living or a personal care home or a nursing home is the most appropriate and safest place for somebody to live after a while, and that can also be recommended and directly arranged for from the hospital. And then you can also expect support for the caregivers, ideas of how to make caregiving easier, how to support the people who are supporting the patient, which is, leads to better long-term outcomes for everybody. And so there are some challenges, though, specifically for Huntington's. And the biggest one is that most providers in general, psychiatric providers not accepted, don't know very much about Huntington's. You may need to educate them and tell them how to get more professional education about Huntington's disease specifically. There aren't that many of us who see a lot of Huntington's patients. So, I'm privileged to be in an HD Center of Excellence, and I see a lot of people with Huntington's. And so when one of my colleagues ends up having a patient who has Huntington's, they'll usually ask me or one of the fellows who trained with us, hey, is this what you would do? Is this something that you see? Is this Huntington's, or is this a person who happens to be depressed and also happens to have Huntington's, but they're not the same thing? And so letting the people caring for you or your loved one know that there's more to it is something that you can do to help get care that's more appropriate or most appropriate. And then again, it might not be that Huntington's is causing the problem that you're seeing. It might be something that's unrelated or related and yet can't really be dealt with as being a Huntington's only issue. Needs to be something more than that. Because depression, substance use, they're common everywhere. It's not something that's only for people with Huntington's. So I'm going to talk about a patient that I saw actually just the other day. I've changed I've changed his initials. I've changed some other demographic information there too, because the Huntington's community is small enough that if I gave all of that, somebody might know him. So I don't want that to happen. So this is a 58-year-old guy. He's gene positive for Huntington's, but he doesn't have much in the way of motor symptoms yet. And he was brought to the psychiatric emergency room by the county crisis team because he's got a long history of very heavy drinking, and he had been at one of his usual bars, and he had talked to the bartender about wanting to run in front of a bus and kill himself. This is while he was drinking. So they called the crisis team. The crisis team brought him to the emergency room. And in the emergency room, he was still saying that he was suicidal. And even after he had sobered up, he was still saying he was suicidal. So there are a lot of people who may have thoughts about harming themselves or someone else when they're intoxicated, that it kind of subsides after a while. You deal with that differently. But he had had several past suicide attempts, actually, and several psychiatric hospitalizations. As I said, a heavy drinker. And also would use just about any substance that came his way if somebody else provided it to him. He didn't go and seek other substances, but if somebody had some cocaine, sure, I'll snort some cocaine. Somebody have some heroin, sure, I'll snort some heroin, and had some pretty serious consequences from that in the past, too. Lives alone, and he has a parent who has HD, who was diagnosed at age about 80. So he had not grown up knowing that he was at risk for HD. He only found out a couple of years ago, and then got tested so that his daughter would know for her family planning. And so not only did he, within the past couple of years, find out that his parent had HD, but also that his brother also has a devastating illness that's not HD. So his family's gotten hit pretty hard pretty recently. And he said that all of this had just become too much, and he just didn't want to live anymore. And so when I saw him, that was sort of the story that he was giving. And he said, yes, I want inpatient psychiatric care. I don't want to feel like this anymore, and I want to stop drinking. Please help me. Okay, so no problem. Perfectly rational decision. Go back the next day, and he says, oh, but I feel much better now. They gave me some Valium for the alcohol withdrawal. I'm not feeling so hungover. I see I might be able to do okay with this. But luckily, he was still happy to go and have his depression and alcohol problems treated. He wasn't saying he didn't want the psychiatric admission anymore, but he was doing something that people will often do, which is say, it doesn't really seem that bad anymore. Maybe I don't need treatment. And so the thing with this is that often with our patients who can come up with a reasonable plan to go home, stay with a family member, check in with them, go to their outpatient treatment that they've already got. If they were basically only suicidal when they were intoxicated, we might say, okay, you can follow up with your outpatient people. I see you have an appointment in 2 days. You've got family. They're telling me that they're going to be with you 24/7. That seems reasonably safe. For somebody with Huntington's, that's not reasonably safe anymore. And that's actually one of the major things that I would like to impart from this talk, even though it wasn't the general subject. The rate of suicide in people with Huntington's is up to 20 times higher than in the general population. It's a really serious problem, and a lot of that is because Huntington's increases people's impulsivity. They're more likely to act on thoughts that somebody without Huntington's might not act on. Depression is also more common in Huntington's. Substance use, which also increases people's risk of acting impulsively, is also more common in Huntington's. All of those things add up to when somebody with Huntington's disease expresses a real wish that they want to hurt themselves, we need to take that very, very seriously. It doesn't mean that they always need to be hospitalized psychiatrically, but we need to pay very close attention to that person and do what we need to do to keep them safe. And so I did transfer him over to the psychiatric unit the next day. Really lovely guy, actually. So when to seek inpatient care is sort of what that's all about. When safety is an issue, and we need to have sort of a higher index of suspicion for somebody with Huntington's, pay a little closer attention to these people in order to keep them safe, because a lot of the suicidality that happens with Huntington's happens earlier on in the course of the illness. So people will have different opinions about sort of end of life suicide, but that's not what I'm talking about. What I'm talking about is people who, when treated, can have a good quality of life and really live for many years after, and live well for many years after, who are thinking about harming themselves. So we really want to think about inpatient care when people are having suicidal thoughts, plans, or actions. And suicidality ranges from the vague thought that maybe it would be better if I didn't wake up tomorrow, all the way to I went and bought a bottle of sleeping pills and now I'm going to take them. And we assess people along that continuum. Similarly, self-injury sometimes happens because somebody truly wants to harm themselves. Sometimes happens because people are trying to deal with emotional pain and substitute physical pain for that. And we need to pay pretty close attention because people can hurt themselves fairly badly, even if their intent is not to harm themselves permanently. Also, aggression. Aggression sort of ranges along the line from lashing out in the moment to that person that my wife left me for, I wish he would die, to I'm going to go get that guy, to I just bought a gun and I'm headed to his house. So we also assess that along a continuum and act to preserve safety as necessary. And then inability to care for or be cared for in the current living situation is another reason that we'll admit people. If somebody's not eating and we need to restore them to be able to eat, if somebody is fighting back against their caregivers so that they can't be cared for properly, that's another thing that we can help people with. So then the next thing is, how do you avoid inpatient care? I mean, to be clear, sometimes inpatient care is absolutely the best thing and the kindest thing, and most people would still prefer not to have to be in an inpatient psychiatric hospital, and I can't say that I would blame anybody for feeling that way. If you establish outpatient care early, it can help, treat any symptoms before they get to the point where somebody is needing inpatient care. It's really important to build a support network for everybody, with family, friends. Paid caregivers can be a very important part of a support network, and then a lot of Huntington's Disease Society resources are going to be very, very useful. But building up as much around a patient to support them and around the caregivers to support them as well. It's important to pay attention to mood and watch for impulsivity and also apathy. Somebody who won't get off the couch to feed themselves, that's something we need to pay attention to and try to do something about. And then again, sometimes it's unavoidable and there's no fault involved. Nobody has to feel bad about somebody needing a psychiatric admission if that's what they need. And people who do their best every day still end up with either themselves or a family member who needs an admission, and that's something we just need to acknowledge. So the last thing I'm going to talk about is what questions to ask when somebody gets admitted. And some of these are going to apply to any kind of medical care. But you always want to know, what's the goal? What's the endpoint of this admission? Are we looking for a medication change? Are we looking for stabilization of a problem behavior, or seeking some kind of higher level of services? Because all of those things could be reasonable goals of an admission. But you want to know, what are you looking for? How do we know that the person who was admitted is better and that they'll be able to function again in the community or in the setting where they're being discharged to? Also, always asking about what the risks and benefits of any treatment that's recommended is. Because it might be that for one person, they may find that oversedation from a medication that controls aggression might be perfectly acceptable, and for another person it might be too much and you need to find a different medication, just for an example. And then you want to know, okay, so everything's okay in the hospital. How do we deal with this when we get home? So that we don't have to come right back. So what strategies can we use to manage whatever kind of behavior or symptom that's being managed well in the hospital? How do we do that at home? Teach us how to care for our family member outside the hospital. What signs and symptoms are there to watch for to know that things are going wrong so we can catch it before another hospitalization is needed? What local resources are there? How do I get in touch with them? Who do we call if I have a problem? That sort of thing. And that's where I'm going to end it. So I'm happy to take questions now, though. So thank you very much for your attention. Good. Yeah. Okay. 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 I'm going to summarize so that people who are on the webcast. So tell me if I get any of it wrong, though. Okay. So what I'm hearing is you expressing frustration about it being difficult to get care because there's such a high bar for being able to get care, and also frustration with the different level of education that different police departments and probably other people as well have in terms of how to deal with people with Huntington's. Mentioning that somebody you were talking to was saying that the police department in her area said they actually had to arrest her husband if she called them. Is that right? Okay, yeah. I feel you. I don't know what to say other than as far as resources for educating the police, one, the society has information, but two, in many areas there are, especially at academic centers, so I don't know if this person lives near one, but if there's an academic psychiatric center, there are often people there who are able to do trainings for police around different kinds of mental health issues, and this would fall under that banner. So that's what I can think of about that. And yeah, the reason I went through the history of psychiatric commitment was sort of to explain why it's so hard to get people care. The pendulum had swung so far towards anybody can lock up anybody for psychiatric reasons, and it swung completely the other way. Which makes it very frustrating to get people care that they need before before something bad happens, basically. And so, yeah, you're right, is what I have to say about that. Did that answer or address your concerns? Okay. Oh, sorry. Mm-hmm. Oh, okay. Mm-hmm. Oh, okay. Yeah. Uh-huh. Okay, so hold on, I'm going to summarize. Sounds like the psychiatrist at the nursing home who has had experience, but maybe not formal training in treating people with Huntington's, um, was less than polite. For that, I can only say I'm so sorry that that's what he said to you, and it's very hard to deal with somebody who doesn't want to do the research on his own. So I can only validate your frustration. Okay. And the suggestion was to call the Huntington Society and give them his name and address, and they will send the information. Okay. All right. And mhm. Yeah. Mhm. Yeah. Yeah. Uh-huh. Mhm. Great. Yeah. Okay. Yeah, so I'll just summarize. The suggestion is to call the local police before there's a problem, particularly with people who haven't had contact with them in the past, which I guess is before there is a problem, and give them information about the person with Huntington's, their specific symptoms, and what you're worried about, and that has been helpful. Yeah, that's a great suggestion. I'm gonna in the back. Uh-huh. Yeah. 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 Mhm. Yeah. Mhm. Uh-huh. Uh-huh. Okay, that's okay. I'll summarize again. One was the another good suggestion about dealing with the police is to have the neurologist write out what the symptoms are and sort of certify that this is a medical illness and not a legal problem, for more information for the police that can be helpful. And the next was a question about even if you send somebody to a nursing home, there's nothing to stop them from calling a cab or an Uber, I guess, and leaving. And how do you deal with that? So that's a really good question. Usually when we're concerned about that and the person really doesn't have the capacity to make that decision for themselves, a situation where family is generally making decisions for the person, we try to get them to a locked dementia unit. So it's a place where they actually can't call a cab and leave. It tends to be the kindest and most humane way to do that because the staff there are also trained for dealing with those kinds of issues. Well, when they at a locked facility, they can actually, because that's what it's designed for. It's not a psychiatric commitment. It's a safety issue. Hmm. Yeah. Oh yeah. Okay. So, yeah. So you had somebody who got the Social Security disability check and then gave him money for necessaries, I guess. Yeah, that's very common. Okay. It's, mhm. Uh-huh. Yeah, and then frustration about fewer beds in locked memory care facilities. Yeah. In Pennsylvania, we're still doing okay with that as far as I can tell, but it really does speak to the fact that there was a place for the state psychiatric hospitals. They had beautiful grounds, people could go outside, they could live like reasonably fulfilling existences and be watched and not locked up all the time. It honestly, progressive Huntington's is one of those things where having access to those would actually probably be more humane and beneficial to the patients than what we have now. So, is there anyone over here? Okay. Oh, in the back. Yeah. Thank you for sharing that. Just to summarize, you had a couple of times when you were feeling suicidal and you got inpatient psychiatric help, and at least this last time was helpful for you, and I'm glad to hear that, and thanks for letting us know. Okay. Yeah. Mhm. Right. Okay, so the question is, you don't always get admitted to the same place every time, and any recommendations about, is it about educating people about HD or just the whole? If you can get records from each of those hospitalizations and have them ready for the next one, because we're still in a situation where most hospitals, unless they're in the same network, can't share information. And having the information about what happened before and that they got during the last hospitalizations would be extraordinarily helpful to the treatment team. I think I'm just about out of time here. I can take one more. You- yeah. Okay. Mhm. I'm sorry to hear that your experience was not as it should be, because I try to present it as how we do it in our facility and how I think that the standard of care should be, in some sense, so that people will know to advocate for that they know that those are reasonable expectations to have. It doesn't mean it's always going to work out that way, but validating for people that they should have access to the standard of care and can tell people when they're not providing the standard of care, I think is empowering, at least to an extent. So I wish your experience had been different, and thank you for saying that. I appreciate it. Okay. And thank you all for listening.